All right, so I took this course last year and I recertified last year, and the course was very helpful. But since I took the course last year, I also know that late in the day, it gets very difficult to kind of hang in there and pay attention. So kudos to everybody who's still here. We'll try and go through this relatively quickly. I'll concentrate, there's some developmental questions, there's some kind of derm questions, and then some sports medicine questions, as Dr. Sabella mentioned. So we'll go ahead and get started. These are all kind of board sim questions. So first question, the parents of an otherwise healthy 14-month-old are concerned because the child is not yet walking alone. He is able to pull to stand, he cruises, and he has a 6-word vocabulary. So the next most appropriate step in this child's care is neurology consultation, physical therapy for the child, simple reassurance, a muscle biopsy, or obtain serum and urine for amino acids and urine for organic acids. Good. So that's what we were hoping for. So simple reassurance was the answer. Walking alone is a developmental task that is usually mastered between 10 and 16 months. And certainly this child is developing normally. He has ability to cruise, ability to say some single distinct words. And so he appears to be developmentally appropriate. Second question, a 12-year-old female soccer player comes to your office with complaints of anterior knee pain. It seems to hurt most with activity, especially when she jumps and kicks a ball. She does not remember any injury. So the most likely cause of her symptoms with that history is an ACL strain, patellar dislocation, a distal quad tear, tibial tubercle apophysitis, or shin splints. All right, so the answer we were looking for is Osgood-Schlatters disease, or tibial tubercle apophysitis. Most common between the ages of 10 to 15 years, and anybody who's spent time in a general pediatric office certainly has seen this. So the exam is positive for swelling and prominence at the area of that tubercle. And treatment is to try to identify training errors. I usually counsel families that this, they're kind of in it for the long haul. There's no quick fixes for this, but you can try and help it by decreasing kind of frequency and intensity of exercise. Stretching may be helpful, and then certainly ice post-activity. And I usually tell people, again, that it can be somewhat of a chronic condition. So again, you can see the tibia tubercle there at the growth plate. All right, so question 3, an 18-month-old should typically be able to stand on one foot, jump off the floor with both feet, walk upstairs with alternating feet forward, or walk backwards. All right, so we'll go through this. These developmental questions can be tricky. I've recerted twice and took my initial boards, and certainly every time, even though I do this on a daily basis, they are kind of tricky. So standing on one foot should be average, attained at 23 months on an average basis. It's going to vary as all the developmental milestones do. Jumping off the floor with both feet, usually an average of 23 months. Walking upstairs, usually average of 30 months. So for this 18-month-old, walking backwards usually can be accomplished at 15 months. So that's the reason for the answer. So back to a sports question. So a 16-year-old wrestler has been encouraged by several people at his gym to take anabolic steroids. He is considering it as he hopes to get a college scholarship. And so he goes home to search the internet about any negative side effects. And all of the following are potential side effects of the anabolic steroids except So testicular atrophy, late epiphyseal closure, aggressive behavior, elevated blood pressure, or elevated liver enzymes. Good. So that's what we're looking for was B. So potential adverse effects are listed here. Certainly psychological effects may be seen. Dermatologic effects such as increased acne can be seen as well. So with the steroids, the adverse effect is early epiphyseal closure, not late, and certainly an increased risk of muscle and tendon injuries. Cardiovascular effects, including high blood pressure or increased cholesterol, can be seen. Hepatic injury and liver enzyme elevation can be noted, and then the genitourinary side effects as noted as well. So question 5, a previously healthy 7-year-old girl presents with patchy scaling of the scalp along with some hair loss. And so potassium hydroxide staining of the scale and hair reveal branching fungal hyphae. Which of the following is a true statement concerning the treatment of this condition? So routine screening of liver function tests will be required over the course of the treatment. Adjunctive antibacterial therapy will likely be required. Topical antifungal agents should be used to avoid possible side effects of the oral medication. And then treatment with systemic antifungal therapy for several weeks will likely be required to eradicate the infection. All right, good. So the majority got that right. So Tinea capitis, again, this is something that probably everybody has seen. There can be many forms that you can see, from patchy scaliness with some hair loss to discrete areas of hair loss and broken hairs to pustules, and then to an inflammatory mass. The trichophyton tonsurens is the most common in the Americas. It does not produce fluorescence on a Woods lamp exam, and as we know, systemic therapy is required. There's a couple of kids with tinea. So griseofulvin, it remains the preferred therapy. It has a good long-term kind of safety profile. Other options are listed there as well. A prolonged course is typically required, usually at least 6 to 8 weeks, or at least 2 weeks after clinical resolution. Adverse effects are fortunately rare, but you can see an elevated transaminase, but not often enough that you have to screen with tests before starting. Adjunctive treatments are selenium sulfate shampoo and rarely corticosteroids. So question 6, back to sports. An 18-year-old basketball player injures his knee during a game. He remembers someone falling on the outside of his knee as he was pivoting on his foot that was planted on the ground. So his knee exam 18 hours after the injury shows a large effusion. So obviously when looking at sports medicine histories, it's interesting and important to note the mechanism and kind of where the forces are being applied to whatever body part is injured. So in this case, with that story, the most likely diagnosis is an ACL injury, a patellar tendon injury, a ruptured popliteal or Baker's cyst, patellofemoral tracking syndrome, or an LCL, lateral collateral ligament injury. All right, so with the LCL, because in the description, he was actually hit on the outside of his knee, the lateral aspect of the knee, which would, if there's going to be an isolated, just one ligament that's going to be injured, most typically that would be the MCL. So it would actually not stress, that mechanism would not stress the LCL, which is why that is not the answer. So the ACL injury is the most likely, also because of the hemarthrosis, or the big joint effusion that's seen relatively quickly. Everything else in those answers, all the other choices, would not typically result in a big hemarthrosis. If you have that effusion, you're going to have that intrasubstance ACL ligament injury. This would occur after skeletal maturity. Before somebody reaches skeletal maturity, you might have an avulsion fracture of the tibial eminence. So again, the MCL may be injured at the same time as the ACL, excuse me. Initial treatment, you're just going to try and decrease swelling if you can and increase comfort, and certainly surgical stabilization is most often necessary. So again, in the diagram here, in the top, there's a partial tear. In the bottom, there's a complete intrasubstance tear, and then that's the tibial avulsion fracture. All right, so question 7, a 6-year-old boy presents to your clinic with a 1-month history of intermittent anterior thigh pain, followed months later by a 2-month history of a worsening limp without pain. You obtain some x-rays and you diagnose Legg-Calve-Perthes disease. So which of the following is a false statement regarding LCPD? So again, which is false? It is more common in males. Abduction and internal rotation are usually limited. It is most common after 10 years of age, or it is usually unilateral. All right, so C is the correct answer. It usually occurs in younger kids. So we'll go through this a little bit. So what is it? It's an idiopathic osteonecrosis or an avascular necrosis of that capital femoral epiphysis. And so it's most common between 3 and 12. Males are affected more than females. Usually it is unilateral. And kind of the classic description is that you can have pain and limp at first, but then sometimes somebody may present with a painless limp. You usually have a loss of abduction and internal rotation on exam. The favorable prognostic factors are listed: younger age, short disease duration, and less epiphyseal involvement. Goals of treatment make sense that you want to try and maintain the motion and maintain that acetabular containment of the femoral head. Observation may be a treatment choice, orthosis or surgery. And again, you can kind of compare a normal-looking femoral head there to an abnormal-looking femoral head on that right side. All right, so concussions, certainly we hear a lot about this nowadays. We see a lot of kids in the office with concussion, and it is kind of ever-changing, so I'll kind of keep it somewhat general with this question. So regarding concussions, choose the following statement that is false. The majority of concussive episodes in young athletes are not reported. There should be loss of consciousness for there to be a diagnosis of concussion. Multiple concussions can result in cumulative brain damage, or close observation of the athlete is of critical importance after a head injury. All right, good. So there does not have to be a loss of consciousness for there to be a diagnosis of concussion. So again, I won't kind of read through the slides too much, but it is important to note that there's a variety of signs and symptoms that can be associated with concussion. I think that in the general population, with all the concussion education that's been going on in recent years, I think more people know this than used to, but it could include alterations in consciousness, confusion, amnesia, visual and hearing impairment, irritability and mood changes, difficulties with balance, headache, lethargy, insomnia, memory impairment, or nausea and vomiting. So football, soccer, and lacrosse have the highest rates of concussion amongst high school sports. A few years ago, there were grading scales that were used. Those were abandoned. And like I say, that still to this day, treatment is somewhat controversial. I think everybody would agree that physical and cognitive rest, to at least some extent, is an important part of treatment of concussion. And then followed by a sequential functional progression of increase in activity as the symptoms are clearing. And symptoms obviously should not return with exertion. This is just an example of a stepwise return to play protocol. And then, if a concussion, if symptoms are ongoing, neuropsych testing may be required, and then post-concussive syndrome can involve residual symptoms such as headache, dizziness, irritability, difficulty concentrating, and so these can occur really after any concussion regardless of the severity of the initial presentation. All right, so question 9, another basketball player. So basketball is my favorite sport. So a 16-year-old male basketball player who is about the 50th percentile is being seen for height, is being seen in July for a pre-participation sports physical. You notice that he has a little bit of blood pressure elevation, and you confirm this on subsequent visits. And so you sit down and talk with the family and the patient about hypertension. And so all of the following points are correct except he should adapt healthy lifestyle habits such as avoiding anabolic steroids, drugs of abuse, and high sodium intake. He should avoid sports such as football and basketball, which may increase his heart rate, and choose a more sedentary sport such as weightlifting. He should have his blood pressure monitored regularly every 1 to 2 months. And if cardiovascular disease coexists, the type and severity of this disease should impact your decision regarding his sports participation. All right, good. So the answer I was looking for was B. So according to the June 2010 AAP policy statement, this kind of falls into stage 2 hypertension. And so in the presence of significant hypertension in the absence of target and organ damage or concomitant heart disease should not limit a person's eligibility for competitive athletics. And again, somebody with this type of hypertension should be restricted from high static sports such as weight and powerlifting or bodybuilding until their blood pressure is in the normal range after lifestyle modification or drug therapy. All right, so back to another orthopedic case. A 13-year-old boy complains of a 4-week history of limping and thigh pain. He does not remember any definite trauma, but does recall an upper respiratory infection somewhat remotely 3 months ago. His exam is positive for a mild decrease in internal rotation of the hip. And so given the clinical scenario, the most likely diagnosis is a transient synovitis of the hip, a hamstring strain, spondylolysis with referred thigh pain, or slipped capital femoral epiphysis. All right, so the answer we're looking for is actually D, and we'll go into why transient synovitis would be unlikely. So it usually occurs in younger children. This person in this story was a 13-year-old, and usually occurs relatively quickly after the viral infection. And I think I mentioned in the clinical scenario that it was a remote infection kind of 3 months ago. And then duration of symptoms have been ongoing for 4 weeks or more, and the duration of symptoms of transient synovitis are usually less than 3 weeks. So just a couple of quick things about SCFE. It's a most common athletic hip disorder. The cause is really unknown. Usually presents in early adolescence or the preteen years, a higher incidence in males and African Americans and in children who are obese. 25% of the time it's bilateral, but they may not present at the same time. So you could have somebody who has it one time and then it presents at another time on the contralateral side. Pain is certainly common, but 25% of patients may only have kind of thigh or knee pain and not hip pain. So on exam, you would want to make sure if somebody's presenting with thigh pain, check out their hip range of motion. If it certainly seems to be limited, especially internal rotation, then that certainly would be a reason to get an x-ray. So the x-ray is kind of the classic ice cream falling off the bone. The epiphysis is partially displaced off the femur, and we'll take a look at an x-ray in a second. It is graded by degree of slippage. They're classified as stable or unstable. Stable, fortunately, is the most common type. And then unstable, you usually have mild or absence antecedent symptoms, and then you have an acute onset of the slippage. So again, you can see a nice looking femoral head here, and then that kind of ice cream falling off the cone phenomenon on that left side. So treatment makes sense to try and prevent that further slippage and minimize complications by inserting screws into the femoral head. Unfortunately, possible complications can include avascular necrosis or degeneration of the cartilage. All right, so another sports question, this time about protective eyewear. So which of the following is a false statement regarding protective eyewear for young athletes? So all youths involved in organized sports should be encouraged to wear appropriate eye protection. Contact lenses do not offer adequate eye protection. Functionally one-eyed athletes are cleared to participate in sports if they have been professionally fitted with recommended protective eyewear. And skiing, diving, wrestling, and bicycling are all considered low-risk sports. All right, so actually the answer is C, and we'll talk about that, I think. All right, so functionally one-eyed athletes must not participate in boxing or full contact martial arts, even if eye protection is available. So a bit of a trick question. The high-risk sports are listed there. I won't read them to you. The moderate risk sports are listed below. All right, and so I'm going to talk a little bit about heat illness. So the following symptoms are typically consistent with heat exhaustion, except hypotension, nausea or vomiting, profuse sweating, or core body temperature between 101 and 104 degrees Fahrenheit. All right, so a little bit of a mixed bag in the answers. The answer we're looking for is A, hypotension, and again, we'll talk about why that's the correct answer. So it's simply not a symptom of heat exhaustion, which we'll talk about some more in a little bit. So certainly kids have less tolerance to exercise than adults when air temperature is greater than the body temperature, and heat illness is caused by an inability to maintain normal body temperature because of either excess heat production or decreased heat transfer to the environment. So there's a difference between a kind of normal fever response by the body and heat stroke. So the fever is a controlled response by the body by the thermoregulatory centers and the hypothalamus and brainstem. And then with heat illness, the normal heat transfer mechanisms are overwhelmed and the central thermoregulatory control is ineffective. So different forms of heat illness. So heat stress is something that if anybody has kind of exercised in warm conditions, you've probably felt this. I like to run, and during the summer I still run, so sometimes you feel this when you're exercising in the heat. So a feeling of just kind of mild discomfort and a physiologic strain from exposure to that hot environment, but your core body temp stays within the normal range. You might notice a decrease in exercise performance, but typically not many other symptoms. As you progress into heat exhaustion, you're going to have potentially some transient mental and physical impairment. You're going to have an elevation of that core body temperature in that 101 to 104 range. You can have some mild dehydration. You may or may not see sodium abnormalities with that. Usually follows periods of a strenuous exercise or exposure to high heat, or both. And then symptoms, again, are listed. Dehydration, you're going to feel more uncomfortable than you would with simple heat stress. You're going to have profuse sweating, headache. You might see those neurologic symptoms such as confusion. You're going to have thirst, nausea, vomiting, but you're not going to have severe neurologic symptoms. So moving on to heat stroke. You have cellular injury that occurs with prolonged core body temperatures greater than about 106, and thermal injury occurs, and you have kind of a denaturing of proteins, and the injured cells undergo apoptosis or necrosis. The core body temperature is elevated significantly. Certainly you're going to have an exposure to heat, and you're going to have neurologic dysfunction. So difference between non-exertional and exertional heat stroke are fairly obvious. Severe dehydration is common with heat stroke. You're going to have flushed, hot, dry skin. You can have diarrhea, dizziness, vertigo, syncope, confusion, delirium, seizures. So again, more significant neurologic symptoms than you would with heat exhaustion. You can have some GI manifestations. You can have some renal insufficiency. And in really young kids, it could mimic bacterial sepsis. So risk factors, again, somewhat obvious: prolonged exertion in a warm, humid environment. Unfortunately, every year we hear about an infant or a young child dying after being left in a hot car for a prolonged period of time. Lab findings that you can see on heat stroke are listed, including coagulopathy. Sometimes you can see a progressive anemia, thrombocytopenia, metabolic acidosis, elevated liver enzymes, and increased lactate. So treatment, again, removal from the heat source, stop exercising if you're exercising, and aggressive hydration. You want to cool aggressively as well. You want to get that core body temp to less than 102 as quickly as possible. Certainly rehydrate with IV fluids. You may need to use vasopressors if there are shock-like symptoms. You're going to monitor for the for the lab complications that could occur, treat seizures if they are present, and then monitor that neurologic status closely. All right, so question 13. According to the American Academy of Pediatrics Clinical Report on Medical Conditions Affecting Sports Participation, a patient with which of the following medical conditions should you not allow to participate in sports? So an athlete with fever, an athlete with diabetes, an athlete with hepatitis C, an athlete with congenital heart disease, or an athlete with HIV. Good. So the answer we're looking for was an athlete with fever. So we'll go through each one of those. So just like we talked about with heat exhaustion, certainly fever can result in greater heat storage, a decreased heat tolerance, increased risk of heat illness, increased cardiopulmonary effort, and reduced maximal exercise capacity, and an increased risk of developing some low blood pressure. So for diabetes, if they're well managed, they should be able to participate in sports. With hepatitis C, generally they can participate. Skin lesions should be covered, and universal precautions should be observed. With congenital heart disease, obviously people with congenital heart disease should be followed by a cardiologist. Most kids with kind of mild forms of congenital heart disease should be able to participate in sports. Certainly any child with congenital heart disease should be cleared by a cardiologist before participating. And then HIV, most sports you are going to be able to participate. Just like with hepatitis C, you want to make sure you're covering skin lesions, and then you want to follow the universal precautions as well. All right, so question 14. A 12-year-old male basketball player presents to your office who has been having knee discomfort and a limp for 1 week after jumping for a ball and twisting his knee. So on a tunnel x-ray view of his knee, you notice a small round lucency of the medial femoral condyle. So given this information, your most likely diagnosis is chondromalacia, a Salter-Harris 3 fracture of the medial femoral condyle, Syndig-Larsen-Johansson disease, or osteochondritis dissecans. All right. right, so D is the answer. So given that X-ray result, really, out of those choices, the only one that you should see that kind of a lucency would be with osteochondritis dissecans. So it occurs when an area of bone adjacent to the cartilage becomes avascular, and then ultimately it separates, the cartilage separates from the underlying bone. So the exact cause is unknown, but often involves trauma from adjacent bones. You may or may not see a significant joint effusion. Certainly a loose body symptoms, a loose fragment symptoms could be present, such as a locking, a popping, or a clicking. And then if you can get to the articular surface that is injured, it may be, it may be tender, but oftentimes, you may not actually on exam be able to palpate that articular surface. In younger children, usually the overlying cartilage remains intact, and so you don't have that loose body sensation. And then, so that risk for articular fracture and eventual separation increases with age. And then on the X-ray, when detectable, they appear as lucencies in the articular epiphysis. So usually younger kids are treated with observation. You may need to immobilize them for a short period of time. In older kids, arthroscopic surgery may be indicated to try and remove that loose body. And then there are other techniques that they do to try and increase cartilage growth. And then in the knee, the most common site is the medial femoral condyle. So this is a picture of an elbow, and you can see that lucency there in the cartilage and the defect. All right, so an 11-year-old basketball player is being seen in your office after she rolled her ankle inwards during a game the day before, and she complains of lateral ankle pain, especially with walking. Her coach told her that it was a sprain and just wants her to go ahead and play in the championship game the next day. After you decide to get an X-ray, or after your exam, you decide to get an X-ray as she has point tenderness over the distal fibula. So in the Salter-Harris classification of fractures, which class is characterized by a fracture that extends along the physis and into the metaphysis? All right, so B is the answer that we're looking for. We'll go over the Salter-Harris fracture classification. I think a simple picture like this helps me kind of remember this. We'll also kind of talk about a mnemonic, and then we'll go through each of the different types of the Salter-Harris fractures. So there's your mnemonic, which you can kind of read through. So a Salter 1 is a separation through the physis. So a type 1 fracture is a transverse fracture through the physis. You might see the width of the physis increased on X-ray, or might not. And growth disturbance is uncommon after this type of a fracture. And so on the clinical examination in the scenario that we talked about, the child had kind of point tenderness at the epiphyseal plate. So in that scenario was probably suggestive of a type 1 fracture. A Salter 2 fracture is through a portion of the physis, but also extends through the metaphysis, so towards the shaft of the bone. So a type 2 fracture is a fracture through that physis and metaphysis. They rarely result in functional limitations, and it is the most common type of Salter-Harris fracture. And again, those first two types do not have significant potential for growth arrest, fortunately. So moving on to Salter 3, so it's a fracture through a portion of the physis extending through the epiphysis and then entering the joint space. So because of that, it's more prone to chronic disability because it crosses the physis and extends into that articular surface of the bone. So typically it doesn't result in significant deformity and usually has a pretty favorable prognosis. And this fracture is also usually dealt with surgically. So a Salter 4 is kind of through everything, the metaphysis, the physis, and the epiphysis, and into the joint space in that articular cartilage. These fractures can cause premature local fusion of the involved bone, and so therefore they can cause deformity of the joint. And then lastly, the crush injury is the Salter 5 classification and type of fracture. So it's a compression or crush injury of the epiphyseal plate with no associated epiphyseal or metaphyseal fracture. And it is, again, associated typically with growth disturbances at the physis. Diagnosis for this might be difficult because, again, they may have significant tenderness, but it may be really locally. There's really sometimes hard to pick these up on x-ray, and these have a poor functional prognosis. So again, 4 and 5 in particular have the high potential for growth arrest. Salter 3 could have some potential for growth arrest as well. So quickly in the clinical scenario, there was this 11-year-old girl who probably has not reached skeletal maturity yet, so they are at risk. Instead of a ankle sprain or a ligament injury, she is at most at risk for an injury to the growth plate. And so you're going to treat her conservatively even if you have any suspicion of a possible growth plate fracture. So you're going to mobilize her. X-ray findings right away may not show anything, and then if you get an X-ray 7 to 10 to 14 days later, you might see some changes. But the initial X-ray being negative does not rule out a Salter 1 fracture. So when in doubt, you're going to treat those conservatively and splint in that kind of a scenario. All right, so a derm question. An adolescent male presents with a skin eruption consisting of multiple, approximately 5 to 7 millimeter salmon pink macular ovoid scaly plaques. These lesions occupy the trunk in a bilateral, almost Christmas tree pattern. The hands and feet are spared. On further examination, you note a 2 by 3 centimeter oval-shaped scaly plaque on his chest. And of the following, the most likely diagnosis is generalized eczema, pityriasis rosea, tinea corporis, erythema multiforme, or granuloma angulare. All right, good. So pityriasis rosea, again, most people have probably seen this. It's suspected to be due to a virus. You get the Herald patch, which is that solitary oval-shaped pink scaly lesion, and that precedes the generalized secondary eruption. In clinical practice, oftentimes people come in self-treating for what they thought was a tinea corporis, and then they see this rash and they're not sure what to think now. So small crops of macules with scaly center that appear in a fir tree pattern are most common. Usually spares face, feet, and hands, but you can have an atypical forms at times, and it usually resolves spontaneously in a few weeks. So there is a kind of a classic picture of pityriasis rosea. All right, so a breastfed 6.5-month-old, born at 38 weeks, otherwise healthy, whose weight was 2,600 grams, is thought to have vitamin D deficient rickets. So on this 6.5-month-old's exam, it would most likely include all of the following except poor growth, costochondral beating, bow legs, softening of the skull, or widening of the epiphysis. All right, so C is the answer that we're looking for, and basically just due to the patient's age, the fact that he's really not weight-bearing yet. So vitamin D deficient rickets is a failure of the mineralization of the growing bone due to a lack of calcium and phosphorus salts. may occur in breastfed infants who are dark-skinned or those unexposed to sunlight. The following conditions listed may be manifestations of vitamin D deficient rickets, and again, in this clinical scenario, the bending or bowing of the shafts of the fibula-tibial femur would not be seen because they're not weight-bearing. All right, so another quick developmental question. A 4-year-old child should be able to perform all of the following except copying a circle, pedaling a tricycle, hopping on one foot, or skipping. All right, very good. So the 3 to 4-year-old age children should be able to copy a circle, pedal a tricycle, and hop on one foot, and then a typical 5-year-old should be able to skip. All right, so question 19, a 4-year-old boy presents to your office with a history of forearm dog bite, which occurred about 18 hours ago. And so the exam reveals a small 7-millimeter laceration, as well as some adjacent puncture wounds. The mom states the area is much more swollen, much more red and warm than it was just a few hours ago, and she has started to notice some drainage from the wound. So the following statements about dog bites are true except dog bites are less likely to become infected than cat bites. The erythema and swelling noted likely represent infection and not just local tissue trauma. Either cephalexin or amoxicillin would be the best initial antibiotic choice due to good coverage against staph and strep organisms. Or lastly, after copious irrigation, some facial lacerations as a result of dog bites may be closed primarily in the first 6 hours after the bite. All right, good. So C was the answer we were looking for. So approximately 5 to 10% of dog bites become infected. Dog bite infections are less likely than infections following cat bites. Copious irrigation is obviously an important part of the initial management. Obviously, you want to check the tetanus status of the patient, evaluate for any risk of rabies, and then some facial wounds may be appropriate for suturing, especially if it's done early. Crush injuries, hand bites, puncture wounds are associated with the greatest risk of infection. And then organisms are listed, and I won't read all those to you, but amoxicillin, clavulanic acid would treat Pasteurella, methicillin, susceptible Staph aureus, strep species, and anaerobes. So that is the treatment of choice. So a couple more questions. We'll finish up, I think, on time. So parents of a healthy 18-month-old girl are concerned because she is headbanging as she transitions to sleep and then sometimes during tantrums. Her gross motor, fine motor, and social developmental milestones are all normal. Appropriate action by the pediatrician would include a referral for psychological testing, specifically looking for autism, informing the parents that this typically resolves by age 4 years, discussing the increased risk of mental retardation or brain injury in children who bang their head, or inform the parents that this should have resolved by 12 months of age. All right, good. So B was the correct answer. So headbanging is a sleep-wake transition disorder. In this clinical scenario, things like autism really, because the development was otherwise normal, would not be something that we would be thinking about. So headbanging and body rocking are very common. They occur in at least half of kids kind of aged 9 to 12 months, and then about 20% of 2-year-olds, and then they usually resolve by about 4 years of age. They usually last for a relatively brief amount of time, less than 15 minutes, and again, usually is not a sign of any significant neurologic problem, headaches, ear pathology, neglect, abuse, or other. All right, and question 21. So a 2-month-old term infant is not sleeping through the night. You tell the exhausted parents that most infants sleep through the night, which is defined as uninterrupted sleep for 6 to 8 hours. They do this by 2 months, by 4 to 6 months, 7 to 9 months, or 12 months. All right, great. So B was the answer I was looking for. So again, by 4 to 6 months of age, total sleep requirements are about 14 to 16 hours per day, and 70 to 80% of infants will sleep for a 6 to 8 hour stretch by age 4 to 6 months. All right, that is all I have. Thanks for your attention, and I think Dr. Sabella is coming back for another talk.